In 1965, David T. Adler founded a company based on an idea he had for an adjustable, flexible holding and positioning device to be used in manufacturing processes. His concept, called a flex bar holder and positioner, could be easily maneuvered into any one of a virtually unlimited number of positions and then locked securely in place. This product became so popular he named his company, Flex Bar Machine Company, after the device. In the early 1970s, David was contacted by Dr. Mel Greenberg, a neurosurgeon who had an idea for a micro-neurological product that would feature flexible holding arms. Our subsequent work with Dr. Greenberg resulted in what is today known as the Greenberg Neurosurgical System, which features several small flexible arms. By 1974, a gynecologist doing laparoscopy recognized the potential for a flexible holding device in laparoscopic procedures. This led to the first use of what we today call the flex arm holder and positioner in laparoscopic surgery. Remember, these were the days before cameras, and the gynecologist had to hold the laparoscope with one hand, which left only one hand to do any operative procedures. By using the flexible arm, he then was able to use both hands in doing the surgery and effectively doubled the number of instruments he could use in laparoscopy. These medical uses of the flex bar devices led to the development of a subsidiary company called Metaflex. Today, Metaflex is arguably the largest manufacturer of surgical arms in the world. We offer a wide variety of arms for both endoscopic and open surgical and microsurgical procedures. In addition, we manufacture custom arms for scores of medical device companies for use in numerous surgical and radiological applications. One area of laparoscopic surgery that has grown in dramatic fashion in recent years is the need to retract the liver in both bariatric and GERD procedures. Unlike laparoscopes that are positioned and repositioned frequently during surgery, the liver retractors generally are held in one spot with little or no need for movement during the procedure. This has led to the widespread use of positioning arms to hold the liver retractor. This program will look at how Metaflex arms can be used for this purpose. We'll look at how to set up the arm for surgery, how it can be used to hold various types of popular retractors, and how to clean and maintain the device. The Metaflex strongarm holder and positioner was developed to provide an easily positioned device that could be adapted to hold a wide range of laparoscopic devices, primarily those needed to be securely locked in place. A strongarm system is made up of three components: an OR table rail clamp, an arm itself, which can be a single arm, a double arm, or even a triple arm, and any one of several attachments that will hold either an instrument or that are themselves a liver retractor. There are several significant advantages of the Metaflex strongarm system. First, potential labor savings by eliminating the need for staff members who only hold a liver retractor during surgery. Secondly, it can reduce surgeon frustration by securely holding the liver with no drift or relaxation or movement. The strongarm system holds a wide variety of liver retractors with a variety of quick detach options. It's adaptable to many types and sizes of patients and procedures by conforming to virtually any setup position desired. It's also a high quality and reliable device and is manufactured in an ISO facility. To use the Metaflex strongarm holder and positioner, I'd like to review the steps that would be necessary for a typical setup of the system. The first device we'll use is the OR table rail clamp. Now, the first step is to make sure that it's fully open by turning the tightening knob fully counterclockwise. When you're placing this onto the rail, the Metaflex name and the little triangle must face up, and it simply goes onto the rail in this fashion. It can be angled on and simply dropped onto the rail. Now, your typical positioning for this, if the surgeon's going to use fans or similar devices that are inserted in the lower right part of the abdomen, We recommend that the arm be placed along the patient's right side at the hip or thigh level. This allows the arm to be set up low and out of the way of the surgeon's working. If the surgeon's going to use a Nathanson hook, which we'll talk about in detail a little bit later, the better position will be up at the patient's neck or shoulder area, because the Nathanson hook is inserted here and the arm has to come over the patient's shoulder to hold the hook. The next step would be to insert the arm. The arm shaft that goes into the table rail clamp is rounded except for one flat side. That flat side must always face out, away from the patient. This allows the tightening clamp to better grab onto the bar and hold it secure. Once it's in position, you must make certain that at least 1 or 2 inches of the bar protrudes below the bottom of the clamp. Anything that's up too high will not be secure once it's tightened. The upper part of this vertical piece can be preliminarily set at about the height of the patient's body at the point where the arm is positioned. You don't want it down lower so that the arm eventually will be on the patient. If it's up too high, it may be in the way. So if you're mounting this at the patient's thigh and the thigh is about here, I would put it to this position and then tighten this clamp by turning the tightening knob clockwise. That should be secure in the device, and then you can leave this limp until it's ready for further use. All strong arm devices come with what we call a quick disconnect fitting. These fittings allow the introduction of a number of different devices, all of which feature a hexagonal end which fits into the tip of the strong arm device. The fitting has a sleeve that slides back and forth to lock and unlock any of the pieces that are put into it. And here's a close-up showing that there's an etching of a lock and an unlock position to always tell you which direction it has to go in. Now, to insert a tip, be sure that the sleeve is all the way forward in the unlock position, and insert the hexagonal fitting and pull back on the lock. This will securely lock the device in place, and you can give it a little tug to make sure indeed that it is locked in place. Now, to remove this tip, we simply slide the locking sleeve forward and the tip is easily removed. Several laparoscopic procedures require that the liver be retracted out of the way for most, if not the entire procedure. Some of the most common of these are bariatric banding procedures or the bypass procedures, and also Nissens and toupees, which are done for gastroesophageal reflux disease. For many years, the most commonly used retractors for liver were things like kite retractors, fan retractors, and self-forming retractors. All were designed to be inserted through either a 5 or a 10 millimeter cannula. And once in the abdominal cavity, they would be either opened or formed. All of these can be held in place with the strong arm device. We would use one fitted with what we call a stainless steel instrument tip. And here's how it works. The arm will be attached to the bed in the way that we discussed earlier. The positioning is based on where the surgeon expects to place the cannula that will hold the retractor. In our model here, I have a 5 millimeter cannula set up in what would be the lower right portion of the abdomen. Once the device is on the rail and set up, and you might notice that we can place this over the drapes. It can go on over up to 2 pieces of drape, but never over blankets. I've positioned this near the patient's right hip because what I will attempt to do in positioning this arm is come in so that the device is out of the way of the surgeons and also is in the general position of where the retractor will be picked up. I mentioned earlier the height's determined by the height of the patient and should never be so low as to rest on the patient's leg or abdomen or thigh. Also, the final position should allow for the turning knob to be pointing up and easily reached by either the surgeon or the scrub nurse to allow the tightening of the arm itself. Okay, once the tip is in place, the arm should be manipulated to determine the best position to hold the type of retractor being used. So I'm putting this roughly in this position. I'm using a 5mm kite retractor, which, while I'm observing through the monitor, will place this and can begin to make sure that I've got the appropriate position to retract the lever. Then I can bring the arm into position and tighten the knob of the stainless steel tip holder until it grasps firmly onto the retractor, and then I can finish tightening the arm itself. If at any time during the procedure the surgeon does need to move this, the arm can be loosened, the retractor repositioned, and tightened once again. All the tightening is done in a clockwise manner, and until you meet resistance, it's impossible to hurt this device by over-tightening it. But once it's in position, it's rigid and will hold for the entire procedure. In recent years,